most of those classes aren't just begun.
Not even there. Yeah.
College classes. But
I was like, because
Would have been like the 2010, 2011 school.
how we do it?
Remember.
and I can't remember if you can go into this meeting.
I don't think they hired him.
Now let's see. I think it worked well if I stand here because the mic. Not that I'm trying to, be too chummy, but
Which you could say.
Yeah, I only got
Well,
some
it's
more.
like it's like
Only
for this Frank, and it's like he wasn't
support.
like upset about that sort of thing, but the whole comment was really so your boss is like that was really what he was
hello, everybody. Welcome to the second day of Health Communication Barriers, Breakthroughs, and Best Practices, brought to you by the University of Illinois Department of Communication and its Health Communication Online Master of Science program. We're speaking to you from the University of Illinois today. It's noon here and afternoon at the East Coast and before noon on the West Coast. I'm happy for all of you online who have been able to join us, and I'm glad that our presentation will be recorded for folks who haven't been able to see it. So please pass the news along to your colleagues who may not be joining us right now. We're very happy to say that over 630 people have registered for the conference. That's well more than twice as many people had registered for the conference last year. So that's a wonderful audience. Something that's a little innovative this year is that we're making the contents of the conference available to some of our undergraduates for a portion of course credit. And if you're interested in that, if you happen to be an academic or a teacher and want the materials available to undergraduates, please do let us know and we'll let you know how we've been able to pull that off. Now today we have our second keynote speaker. It's Dr. Kim Nazi, and Kim works for the Veterans Administration, which is often the target of public criticism. You might read about it in the papers, and it might be that it's a target because it's so big. It's a very large target. It's the largest integrated healthcare system in the United States. It has over 1,200 facilities, 170 medical centers, over 1,000 outpatient centers, and serves over 9 million veterans. So I think we could probably learn a lot by studying the Veterans Administration, and for that reason I'm very happy that Dr. Nazi has joined us. She is, and here's a little bit of a long title, a Senior Program and Management Analyst in the Veterans and Consumer Health Informatics Office in the Office of Connected Care at the Veterans Health Administration. Dr. Nazi is also a board-certified healthcare executive, a fellow of the American College of Healthcare Executives. She has a master's degree in communication, a PhD in sociology, and in 2012 she won the Warner Slack eHealth Award in recognition of outstanding contributions in helping to define and improve the field of eHealth. Her presentation today is entitled Health Communication, Myths, Legends, and What We Learned Along the Way. And Kim, I want to welcome you and thank you very much for being here.
Thank you so much.
Thank you.
Thank you. Wow. Thank you for that great introduction. I'm so happy to be here with you today. I do work for the Office of Connected Care, and our office is really all about e-health and telehealth. And today I'd like to talk with you about 9 things that we've learned in spending over the last 20 years in implementing our patient portal. And along the way, I hope we can examine, if not debunk, some common myths and legends related to health communication. So I want to start by saying that it's been my privilege over the last 34 and a half years to work for the Department of Veterans Affairs. And many of my colleagues and I have stayed with the department so long because we have the most noble mission to really care and serve and honor America's veterans. The Veterans Health Administration is one part of the Department of Veterans Affairs, and it's actually the largest integrated healthcare system in the United States. We have more than 145 medical centers, more than 1,200 outpatient clinics in communities across the country, along with community centers, domiciliaries, and vet centers. And just to give you a sense for the amount of workload, last year VA delivered more than 106 million outpatient visits, along with inpatient visits, surgeries, and hospitalizations. So it's a very, very large system, and we do also have an enterprise-wide health record system. There are more than 20 million veterans living in the United States, and about 9.7 of those have used a VA benefit, whether it's healthcare benefit, cemetery benefit, education benefit, or home loan, things like that from the Veterans Benefits Administration. About 9.1 million veterans have enrolled for VA healthcare, and last year VA treated 6 million veterans. So that's a little bit about the population that we serve. And what's unique about the VA system? There are many things that are unique about the VA system, but I'd like to say that if you want to learn more about the VA and the quality of care delivered by VA, I'd encourage you to read Best Care Anywhere, a great book in its 3rd edition by Philip Longman. And you'll learn a lot about the history of VA, but also the high quality health care that VA delivers and how and why it does so. Back in 1983, I was a medical technologist in the clinical lab at the Albany Department. DHCP, the first beginning of the electronic health record, was coming about. And one thing that's unique about it is that it operated on a principle of user-centered design. So we'd be in the lab working, clinicians would come in, we'd have clinical applications coordinators, and they sort of built the bridge between the programming world and the clinical world. And they would identify innovations that clinicians would recommend. They would build those, try them out, modify them based on feedback from healthcare providers, and then those innovations could be shared across the system, ultimately really transforming the way that the health record was born. So it was an interesting time to be there. And over the years, it's true that VA has been a little different, not only because we serve such a precious population for our nation, but also because we have really longevity of relationships with our patients. And because of the healthcare model, we're really incentivized to have the best quality outcomes at the lowest cost. So with that electronic health record system that later became known as Vista, we started off in 1999 piloting a program in which we would allow veterans to have access to their medical record data. Pretty groundbreaking in 1999. Over time, we instituted an enterprise-wide patient portal, and this is what came to be known as the tethered patient portal. And our vision has really been to provide patients with knowledge and information so that they could make better healthcare decisions, they could stay healthy, and they could seek services when they needed to. So this is the My HealtheVet patient portal. I mentioned we started a pilot in 1999. By 2003, we had created an enterprise-wide national portal, and it's really a suite of tools. So you can refill prescriptions and track the delivery of those. You can view your VA appointments and get email reminders and notifications. Most recently, we've also added appointment scheduling. So across the country, we're rolling out the ability to schedule VA appointments. You can also use secure messaging. That means you can do system-based electronic secure communication with your healthcare team. And now we're expanding that to other types of groups within the VA, including pharmacists and billing support centers. Really important part of this is access to the medical record data. We do offer a feature called the VA Blue Button, and the goal of that is to really give people access to their data. They can customize a report, they can select the data they'd like to include and the date range, and we will compile a report and they can view and download and share that report. One very special part of that came about in 2013 is called VA Open Notes, building on the early work done by the My Open Notes group, who had physicians volunteer to share their encounter notes with their patients with great success. VA really systematized that and created a system in which access to all types of notes are available to all of our VA patients, including social work notes, nursing notes, mental health notes, all clinical notes. Another thing that we added in that same January of 2013 was the VA Health Summary. So this is a pre-designed set of information, interoperable file format, and that becomes very important as more and more veterans are served in the community as well as by VA providers. And so having the ability to have an interoperable set of data that they can share and exchange is becoming more and more important. We also offer a health risk appraisal known as the Healthy Living Assessment, and a very robust library of trusted education resources, many of which are very specific to the special conditions that the veteran population has. So that brings us to kind of myth number one, if you build it, they will come. So there's been this PHR paradox, right, where survey after survey shows that consumers express a strong desire to have access to their health information. And yet, when we look at the history of the adoption of personal health records, it's been slower than anticipated, although I think it's really growing now. But why is that the case, that consumers really say that they want access to personal health records, but then they really don't adopt them in the quantity that we expect? We've also seen the growth and demise of various PHR models. Back in 1999, when we were building our tethered patient portal, in vogue was sort of this offline, standalone personal health record. Then came the flash drive models and the CD-ROM models. Over time, I think what really emerged was this web-based model so that you could have access to it from anywhere. And if you could tether that to an electronic health record, now you've really got something, right? Give people access to their medical records. We've also seen legislative influences, right? So we've had the HITECH Act and meaningful use incentivized organizations to show that they were implementing electronic health records in meaningful ways by a set of criteria. And most recent stage 3 versions, of course, called for patient portals, secure messaging, giving patients the ability to view, download, and transmit their data. So all of this churn really, one would think, would increase the way that people adopt and keep using patient portals, but we haven't really seen that to be the case. So there are some exceptions. We've learned a lot about what consumers want. Here people are living their lives. They don't go online to check their patient portal for fun. They really do it because they have a reason, and a lot of times it's because they have an acute need and they need to accomplish a task. So they value easy, transactional, convenient ways to accomplish these tasks. They want access to their information. If you can incentivize them to go through the pain of adopting and go through that process. But they really want trusted relationships with organizations and providers. So some organizations have, instead of building personal health record systems, have done pilot programs with commercial systems. And what they found is that trust in the organization and the provider and the holder of your data turns out to be pretty critical. What we also have learned over the last 20 years is that consumer empowerment is important, but maybe that's just part of the equation. So imagine the patient coming in to see the doc, very proudly tracking their blood pressures because they need to get control of their hypertension. They bring in that paper to the doctor, and the doctor says, "What's this?" And they say, "Oh, I've been using my HealtheVet to track my blood pressures. Look at how I'm doing." Doc says, "Thank you very much, that's great," hands it back. What impact do you think that has on the patient motivation to continue to use that system? Bad, right? On the other hand, if you think of a different model in which provider then says, "Hey, your blood pressure's a little high. I'd like to see you in about 2 months, but what I'd like you to do in between is use my HealtheVet to track your blood pressures, and then use secure messaging maybe once every 2 weeks and send me your numbers, and we'll communicate over secure messaging and see how you're doing." Very different model, right? So what we learned is that actually provider endorsement, encouragement, and engagement with patient use of portals turns out to be really important for not just their adoption, but for their sustained use. So our focus shifted to say it's really not just about the technology, it's really about how to embed the use of the technology into the way that we deliver care with our healthcare professionals on board so that it's a tool in the tool chest and one that they use together. That's patient engagement. So I mentioned there are a few exceptions. I'm proud to say that VA is one of them. We have more than 4.2 million users. There is a process of authentication, so we can do in-person proofing one time, or we can do it online if you have a DoD credential. And that's important because that gives you access to all the features, and we know who you are. In fiscal year 2017, compared to the previous fiscal year, we saw a 20% increase in use of prescription refills, 33% increase in use of secure messaging, 38% increase in use of the VA Blue Button feature, which people are using to generate reports containing their medical data. And we know a lot about our users because we've done a consumer experience analytics survey since 2007. Gives us the ability to collect anonymous voluntary feedback with OMB approval. And so what we've learned about that is, why are people coming to the site? In 2007, 76% of the people said they came to the site to refill a prescription. And now that we have more different types of features, we see that spread a little bit. So yes, prescription refill is still a top task, but we also say people really come to view their appointments, to use secure messaging with their healthcare team, to track the delivery of the prescriptions that they've ordered, view their medication history, and also to view their lab and test results and other ways of viewing their health records. Here comes another myth. Older folks won't use technology. Well, yes, they will. 68% of our users are older than 65. In fact, 10% of our users are older than 85. So here we have a cohort, 90% of the veteran population are male, 90% of our users are male as well, but these folks are embracing the technology and using it. And what we also know, because we have a great way to get feedback from our users, is that more and more our veterans tell us that they are also using a community provider. So this really makes it important for us to give people access to their medical records, empower them to share that information, so the right information is available across all settings of care. So what changed that made the VA successful in having pretty robust adoption and use of its patient portal? Well, to find out, we did qualitative in-depth interviews with providers, pharmacists, nurses, to try to discover what they knew about how patients were using the portal. Little disappointing, because turns out they really didn't know much about how patients were using the portal 10 years ago. It wasn't really until we added secure messaging to the portal that things changed, and our providers became engaged in the patient portal and really began to use it with patients. So what was different about secure messaging, right? And when we tried to promote use of other things like, well, we have a health education library and we allow patients to self-enter information, it was really the way that secure messaging was implemented in terms of starting as a voluntary trial. So if you wanted to try it, you could come on board. Secondly, the software was built with a lot of flexibility. So if you're a member of a clinic team and the nurse in your clinic is the one who triages incoming phone calls, you've got a good process for that, you can actually set up the software to do the same thing. So Dr. Smith is not going to get every secure message that comes in if that's not the way his clinic operates triage. The nurse who is assigned to that would take on that role. So a lot of things that happened that made this a way of engaging healthcare professionals. And then once they were engaged, it also enabled the kind of communication that really made the patient use of the other features relevant for the docs, right? So when we looked at medication reconciliation, for example, so before secure messaging, patient can view med list on record. Great, that's important. Patient can self-enter over-the-counter meds, supplements, non-VA prescriptions, also important. But until secure messaging could enable information sharing, hey doc, I stopped taking that because it gave me headaches. Hey doc, I started taking prescribed an antibiotic by my community provider. That's what enabled this to become more important, because medication reconciliation as a clinical process at the end of the day is about communication, right? It's a dialogue, and it can't happen without that dialogue. So here's where adding a portal feature like secure messaging became really important. Well, but portal features like secure messaging, what do we know about asynchronous, nonverbal communication? Can it even be effective in building and sustaining relationships? And what we've discovered is that this may be another myth, right? So what we found, and this comes from qualitative interviews with docs, pharmacists, and nurses, is that it actually improved connectivity with patients from the perspective of the providers. And of course, it certainly improved the patient perception of access. And what the docs liked about it is that inherently communication was more direct and focused, because now people are constructing their message instead of the hand on the doorknob as I'm going out of the clinic encounter. And you know that telephone tag is a big problem in healthcare centers. And so this way I could respond in my own time when I have time, and I don't have to call you back after you called me and I couldn't take your call because I was in clinic, and now I reach you directly. But some other interesting communication things really happened, right? People said that they got to know their patients better, really, using electronic communication. And one reason that that happened is because one phenomena that we discovered was that the threshold at which patients would initiate communication was lower. So I may be wondering, I've had a few headaches today, I don't know if I need to be seen, I really don't think I need to call or visit. So there's kind of a high bar where patients really don't want to maybe trouble their healthcare provider. But with secure messaging, that threshold is quite a bit lower. So they might not want to call, they might not think it warrants driving to the facility, but it's a low cost to send a secure message. And so docs started hearing from their patients more, and when they did see them periodically in in-person encounters, they actually had engaged with that patient in between and learned more about them and knew them better and kept track of what was going on. So that was a really interesting finding in terms of secure messaging. And at the end of the day, it really improved their communication, the patient satisfaction, and in fact, many providers reported that it improved their relationship. So that was number 2. So in addition to thinking about healthcare providers as being important engagement artifacts within this ecosystem of patient portals, we also thought about secure messaging and the importance of interactive communication. But we also learned about having to pay very close attention to ergonomics, right? So there's the physical, social, and organizational structures, and turns out little things make a big difference. So when we talk to nurses about why aren't your patients, why aren't you telling patients to look up these education resources on my HealtheVet? And they would say, you've lost the teachable moment, right? If I only had a computer, right, where I'm educating the patient after the provider leaves the room, I would surely point them to my HealtheVet, and together we could walk through it. So little things like understanding where the patient touch points are, understanding the process in which care is delivered, and thinking about how technology can be embedded in that rather than something, maybe you'll go home and do later on, I think is really important. So another thing that happened when we talked about the importance of paying very close attention to clinical adoption is that in January of 2013, following on the heels of the Open Notes project, we introduced full access to all clinical, social work, mental health notes. But what's really important about this is, first of all, that we were able to replicate the findings from the Open Notes study. So we were able to show that there are many positive impacts of that. But the part of the story I want to tell you about here is really what we did the year before we did this. So we convened a multidisciplinary work group. How happy do you think all the providers were that we were going to open up a portal access to notes? There were some concerns, and a lot of those concerns were valid concerns. Docs worried that patients would be confused or worried or anxious. They worried that they would use many of the precious minutes of their encounter answering questions based on the notes. They worried a lot about those things. And so we spent about a year with a group of physicians, providers, social workers, mental health professionals, and really prepared as an organization so that we could hear those concerns, we could come up with strategies to mitigate those concerns, and we could do a broad reach through every corner of the organization to socialize this idea that, hey, the patient is going to be an audience of your note. And then the second thing that we did was, based on this kind of principle of the social life of information, we did it prospectively, right? So we didn't say, here's every note you've ever written since 1986 when you thought you were just writing to the other docs in the group. Instead, we gave a lot of educational opportunities, and then after a year, we said, from this date forward, notes will be available through the portal. Now, notes are available through release of information anyway, but you can't underestimate the impact of providing easy online access to the notes. So that's a great success story, and we had some great moments in that where we would interview recovery coordinators who were dealing with veterans who were receiving mental health notes. And when we talked with them about what it was like for you to read your note, I think I could summarize it by saying it was a hard read, but in the end, having read that, it really made a difference in my path forward. And so there is potentially a therapeutic benefit to that. And so this is a great story of where not everyone in the organization, the culture is really thinking about giving patients full access to data. There's a lot of norms in which we may think we have to protect patients from information. But it's a new world order. And we're really leading the edge here in providing patients with full access. And as you can see, the outcomes are very positive. Which brings us to number 5. So I told you a little bit about how the VA's electronic health record system was designed, and part of its success was because it was based on principles of user-centered design, right? And so we tried to do the very same thing with the portal. So this idea of user-centered design is a philosophy, so you need to know who your users are, what their goals are, what their tasks are, even what their limitations are, and then design the software and the technology around what you know rather than the reverse. I'll just give you a couple of examples of how we've used that. We do have some restrictions in terms of collecting data from people, and so one method that we have used is this customer experience analytics tool chest, and we can ask model questions so we can quantify satisfaction and trend that over time, but we can also develop OMB-approved custom questions. So we've posted questions about various things. One of the questions we've asked since 2007 has been, what additional services do you want for the My HealtheVet portal? So here's what that looked like in 2007, right? People wanted to view their appointments, be able to schedule or change their appointments, look at information in their medical record, and they wanted to be able to communicate securely with their doctor. As you've heard so far, we've implemented all of these things. So that's the good news. So what does that look like in 2017? What we heard in 2017 before we were able to implement online scheduling is the number one requested additional service. I want to be able to schedule an appointment. So I'm happy to say we are in the very final stages of rolling that out. We also have people wanting to be able to view a list of their healthcare providers. So we're adding that to the VA Health Summary. People want tools to be able to check for drug-drug interactions and also to be able to view and pay their VA bills and co-payments. Now, another myth might be, wow, government moves slow. I'm happy to tell you that these are all on our roadmap for this year, so you can debunk that myth as well. Another way that we collect data is open-ended data. So there is nothing like hearing in the voice of the person that you are serving what their opinion is. So this has been a very valuable tool. So here we are in January. Providers have concerns about people having, access to lab test results. We go out the door with a 7-day hold. They're available 7 days after verified. And what do you think veterans said, right? Not good enough. So within 6 months, we were able to put together a compelling case that veterans want more timely access to their lab results and change that. So by June of that year, we actually dropped the hold period from 7 days to 3 days. We'd like it to be 1 day, but there are still some valid concerns, so we have to kind of find the sweet spot. So number 6, I just wanted to talk a little bit about patient empowerment because in the last couple decades, there's been a lot of focus on consumer empowerment, right? I think I was even on a couple of consumer empowerment work groups. And it kind of is a gloss, right? So what does that really mean? If you were to say what's the lingo today, it would be patient engagement. So everything is, patient engagement. And I think they're really important, but you sort of have to unpack them to really understand what they mean and to do things that make them happen, right? So it's both a process as an outcome. And I think, as you see from this quote, one critical part of really empowering patients is to give them access to information. So yesterday, Dr. Street said that communication was the cornerstone of healthcare. And I'm going to go one farther and say information is the currency of healthcare, because really that communication is all about information. And as you know, healthcare processes are very information intensive. So one thing that we've tried to do is we've really tried to take the technology and embed it into the fabric of the way that we deliver care, is really to think about the patient journey, right? So most of the time, here we are living our lives, right? And then we may have a concern or we may have a chronic condition that requires ongoing management. But if we think about this, what that experience is, what are the processes that happen in determining if I need a visit? And could I use secure messaging to accomplish that task? What are the things that would be helpful in preparing for a visit? A good example would be some of our researchers were studying pre-appointment planning, right? Wow, what if I could send you a secure message and you could write back to me and have reviewed the med list and tell me your 3 goals for our encounter, and that's going to be the agenda for our time together, right? Game changer. So thinking about this from a process perspective, rather than thinking that the technology is really the important part, this is really the important part. Another thing that's come up recently is that, well, we're a patient portal. People love personalization. Let's just personalize the portal for them. And we've had to take a step backwards, right? First of all, we talk about personalization and customization. It's important to know that they're different, right? So personalization is done by the system, right, as it knows you and your characteristics. Customization is done by the user. So the system allows the user to make changes, have preferences and settings so that the technology serves you in the way that you'd like it to. And they are very different. So let's walk through a couple of examples, and I think we'll get a flavor for the good, bad, and the ugly. So Mary logs into My HealtheVet. She was able to get to a video which described an upcoming procedure that she had. So she was well prepared because her physician had prescribed an educational asset for her. So that's a great example. So personalizing based on this particular user's education needs, I think, can be very helpful. Second example. So John logs into My HealtheVet and was very offended when the system, what he perceived to be, labeled him to view substance abuse and bipolar depression educational content based on the ICD codes in his problem list. So sounds like a good idea, right? We know what problems you have on the problem list. Let's show you education based on that. But you have to think about the consequences of that. So Peter logs in, was able to modify the portal so that it displayed the most commonly used tasks that he performs, and that improved his satisfaction. And then lastly, here's Mike, who logs into My HealtheVet, and he's able to select the types of educational content that he'd like to see because it's recommended to him based on a list of options. And maybe those are based on his ICD codes. So what's the difference here? The difference in this one is this principle of agency, right? So if you can recommend, you can suggest, but let me choose, right? So we have to be careful that we think about portal enhancements that we know our customer, know some of the trigger points, and also realize that these things are different and that we can do it, but we have to do it thoughtfully and carefully and get a lot of user feedback on what would be most valuable. Turns out for veterans, what they'd like is to display their branch of service and maybe change their salutation because that's important to them. When we look at the research on personalization and customization, it's kind of like that consumer empowerment thing, right? It's very glossy. And so there's a lot of papers out there about how great it would be, but not much about what it looks like. Some promising areas to pursue, I think, would be patient-tailored decision support, personalized wellness reminders, which My HealtheVet has, and alerts for preventative screenings. When you look at the literature from PHRs on outcomes, it's mixed, right? But some of the most promising things come from preventative screenings to be able to close that gap of care. Which brings us to number 8, and you're all still hanging with me. So our early version of the portal, circa 1999, was functional but not pretty. When we launched in 2003, I think it was pretty contemporary for the times, but I think you'd agree website design has changed over time. So one of the things we'd wanted to do is take everything we've learned from veterans over the last decade and finally, kind of change our information architecture, make the changes that we know would be important to people based on what we've learned from them. We also have a great human factors engineering group who can do, customer-focused testing, so we use that as part of our process. So here's what we looked like in June of 2016, and we wanted to implement a dashboard so we know what the common tasks are, put them right up here on the top of the homepage. But we were a little worried about pulling the rug out, right? So we've got users who have been using the product since 2003. So what we did to start in October was we added something. We really didn't take anything away. You still get the nav bar there and everything, but we added something. And that worked out pretty well. So then what we did in September of 2017 was kind of a fuller scale redesign. We've got more work to do in terms of information over architecture, but we applied kind of this consistent theme across all pages, added breadcrumbs, kind of things you'd expect. So what do you think happened? Well, this myth is called change is good. But anyway, so I mentioned we can quantify our customer satisfaction and we can trend and track that. We use a survey tool that's used by Fortune 500 companies, so we can also benchmark. Have you ever heard of the eGov index? Kind of a metric which measures citizen satisfaction with e-government. That also uses this same tool, so it's an industry standard. So we can track satisfaction over time. And when do you think that first change was deployed to this site? If you guessed it's when that dip happened, you're right. And there's this principle called change aversion, right? So look, I just came to refill my prescription, and now I have to figure out how to do my task all over, and I don't care if it's prettier, I really just need to do my task, right? People don't use portals for fun, they use them because they have a need, and often that need comes at a time when they also have a lot of other stuff going on. So what you hope, you expect it, right? We weren't worried. But what you hope is that you pretty quickly recover. What you really hope is that your design change is good and that you reach a new level of customer satisfaction, which is the good news because that's in fact what happened. So now you're wondering, hey, I wonder what happened when they did that bigger change in September. Well, here again, this is picking up where we left off. So historically, since 2007, we've come in about a 75. It's really hard to move these numbers. And so we saw a nice bump up after that October change. Then we made another change again with that theme redeployment. And again, what we saw was that initial decline in satisfaction where people get a little frustrated that you've made a change. But we saw a nice service recovery. What I want to point out that since 2007, this is the highest customer satisfaction score that we've ever had. So that tells you that your design change was good. If you can survive the pain of change with your users and help them along the way, then we can see positive impact of having redesigned the site. And lastly, number 9. So little things make a big difference, right? So one thing that we heard from our users is like, there's so much text on the screen. So just by making simple changes, and I kind of think of this like which tool is right for me, right? When you go to the patient portal and we've got different information products, how am I supposed to know, right? I am going to see a community provider that I see every 6 months. Which one do I want? Which tool is right for me? So what we're trying to do is think about the patient experience and really use that to give people the power to make the information decision that is best for them given all things in their circumstance. So we're moving away from this and moving to that. And that actually deploys March 10th. A little worried we're going to see that kind of dip, but we expect it and we hope to reach a new level of recovery. So I want to close by kind of channeling a couple of thought leaders. My primary role for our portal functionality is program evaluation. So the first thing I did was make friends with all the VA researchers because they've got skills and talent and money. And kind of collaborating with them, giving them our research agenda has made our evaluation program successful because it's based not only on the kinds of tools that we have in our tool chest like customer experience analytics, but also really sound, rigorous research findings. And for that, I'm very thankful to all of the VA researchers that we work with. So I want to kind of end on a spin with program evaluation, and this is Peter Drucker, who said, if you can't measure it, you can't manage it. So that's been really important to us. Sometimes we try to imagine what users will think or what they want, and in the end of the day, a lot of times we're surprised. So really being sure that you understand your user and that you're constantly reaching out. So customer input drives priorities. Ask them what you don't know, but also ask them what you think you do know, because you might just be surprised. Next, we'll hear from Albert Einstein. This is one of my favorites. So not everything that counts can be counted, and not everything that can be counted counts. And it might be my favorite because I do work for the government, and we do a lot of counting and reporting out. But one thing that I think is clear from all of our work with working with veterans is that there is nothing more compelling than a veteran saying what he'd like in his own voice. So I think it's important to not only use quantitative techniques, but also qualitative techniques. So both become important, and if we can use them in tandem, I think we get a better understanding of the patient experience. And as we try to serve them with technology, isn't that really what it's all about? And then lastly, this is George Bernard Shaw, who said that the only man who behaves sensibly is my tailor. He takes my measurements anew every time he sees me, while all the rest go on with their old measurements and expect me to fit them. So this principle of user-centered design, I feel like we've got a really good channel through which we hear from our customers. It's helped us to identify features that we could add to the portal and prioritize those given the resources that we have. It's allowed us to prospectively make decisions about new functionality. It's also allowed us, as you saw, to change policy, for example, for release of lab results. And so I think it's really important way in that we think of it as user-centered design as an implementation strategy along in tandem with other implementation strategies. So lastly, I just want to share with you kind of a final thought. Given what we know about patient portals and that the evidence still remains to be mixed about their impact on outcomes. We see some promising results, but at the end of the day, I think that really the anticipated benefits, they're there, but it requires sort of this synergy between the science of informatics and the art of medicine. And so that's the magic. So as you kind of study health communication, I think you really need to think about it from both of those perspectives and think about the magic that lies between. And with that, I give you my contact information. I am retiring from the VA after 34.5 years at the end of March. So you can reach me at the top address before then and at the bottom address after then. And I'm happy to answer any questions. Yes.
Hi, Kim. Thank you for that presentation. It's really interesting and a great example of how to kind of think about design and e-health in general. At the end, you were talking about usability enhancements, but I'm wondering what kinds of accessibility enhancements or things you've had to think about, since individuals will have different accessibility issues.
Yeah, that's a great question. So she's asking about accessibility, and I think the VA does a fantastic job in terms of designing and deploying technology in accessible ways. We have a 508 compliance unit. So every software, every technology, everything, every presentation that we put out for public consumption first goes through that group. And so we've got a set of standards that must be met. Even public presentations, need to go through that. So there's meeting the criteria at the lowest benchmark, but then there's exceeding the criteria. So we have a great collaboration with many parts of the organization. So for example, we've got the veterans, the Blind Veterans Association. So they actually partner with us, and they will do screen reading using JAWS and other technologies of our content to tell us it may meet the design and the compliance with the 508 law, but does it really meet the need of the user, right? Or maybe if you designed it in a different way, maybe you didn't use, some different tags, it would actually, maybe it's compliant, but I got to read through everything to get to the task, right? If you put the task link at the top of the page. So I think we do a great job of that. And people also have other types of accessibility needs, in addition to kind of some of those that we mentioned. All of our content is at an 8th grade reading level, and we believe in principles of plain language. And we also know that people have mobility problems, and so I think we've got a great way of, especially for this important population, making sure that we not just meet, the low bar of the standards, but really try to exceed the standards.
We have an online question here from Claudia. She says, hi to all on the second conference day. Great presentation. Thank you. One question. Are there differences as sicker people get that they would use less the patient portal? Could that be expected?
So Claudia, thank you for that question. And we've got several studies underway looking at this. I think when we look at our patient population, especially you saw that average age in the patient population and in the portal users is 65 or older, you won't be surprised that they have many chronic conditions, and I think on average, the average user has at least 5 comorbidities. So that's pretty substantial, and so I think it's that we wonder sometimes why these younger veterans coming out of the service might not be adopting in the same proportion as the older users, and I think it's a great point. It's probably because the more chronic conditions one has, the more useful the portal services are. So you think about young, healthy adults and what their care needs are and services to interact with the organization versus someone who has one or more chronic conditions and may be sicker. And so I think that is true of patient portals in general and definitely true of our population.
Go ahead.
Yeah, speaking of your population, you said a couple things about comorbidities among the older portion of the population. Is there anything in general that you've learned about the VA's population that is importantly different from the national population or the non-VA population with respect to the use of the portal?
So I think the question is there anything unique about this particular population as it interacts with the portal that may be same or different than the national population, right? I think one thing that's true of our population is it's predominantly male, predominantly older, but I think also the experiences that people have had in the military make them unique. And so I think one thing that's different about our patient portal is really thinking about users who may have special requirements and being able to design the approach and the educational content and the messaging, keeping that in mind. I think this is a really important national population and one that has some nuances to it. And there's been a lot of good, really important VA research in general about the population. And I think what we try to do is learn from those findings and apply it to the population that's also using the portal.
Right, and I'm just wondering whether are there things that can't be, that are learned with a VA population that wouldn't apply to a national population? Or conditions of the national population, non-VA population, that would be requirements or conditions or capacities for the use of a portal that aren't present in the VA. I'm just wondering, what's the generalizability of the findings of the VA's population use of the portal?
I think the generalizability of the findings, these principles, are broadly generalizable.
Okay.
I think one of those principles is that you really have to have a deep knowledge and understanding of the people that you're serving. And so I think we may find that a different patient population may have different additional desired services, may have different preferences for customization and personalization. So I think it really, the principles apply broadly, but then you have to apply the principles to your specific population.
Yeah.
You know what I mean?
Yeah, well, you and I were talking about it earlier, and it seems, what my limited experience with the VA is that in a way it is, I think, friendlier to its patient population than other health systems are to their patient populations. There is a sort of sense, in the, shall we call it the private sector, that it's an exchange relationship between the patient and the organization. And then in the VA, it's almost as if you're a member of the family. Your status isn't questioned. It's been established by virtue of the fact that you serve the country. And it's almost as if the first thing that anybody says to veterans is thank you. And then they go on with the healthcare, as opposed to where's your, well, okay, the first thing they say is what's your last four? That's the, what's your last four? But everybody has a social security card. They don't say, let me see your health plan ID, what's your copay, and so on.
So that's a great segue for that. I appreciate that. So I think you're right. I think what is probably unique about VA healthcare, in addition to the things that we talked about, is really this focus on whole person health, right? So VA is committed to not just your healthcare problem and helping to solve that, but also being sure that you have all the things that you need in terms of socioeconomics, in terms of emotional and mental health, and in terms of basic living. And there's also a very important camaraderie among veterans who share a common bond for having lived through, that experience. So I think what's also great about our department is that we do employ a lot of veterans. And so a lot of the veterans who are caring for veterans are veterans themselves, and so have a unique understanding of not just military culture, but also the experience of the patient before them. And in addition to that, I think we employ a lot of volunteers who are also veterans, and there's this concept of kind of peer mentoring. So do you think that a veteran who is new to the VA would like to hear about it from me, or do you think they'd like to hear about it from someone who served in the military and can help them kind of navigate the system because they've navigated the system, right? So I think this idea of whole person health, we are very strong proponents of patient-centered care. So we've got an Office of Cultural Transformation who is focused both in supporting employees to support patient-centered care and defining and executing programs that support patient-centered care. And I think it's been a fantastic system in terms of providing that kind of whole person health care.
Thank you.
We have another question here from Edward. It was noted that physicians advocating for and using the system themselves is important to encourage patient use. What strategies do you have to promote physician use and buy into the portal?
So early on, I think the education and marketing was focused at the veterans, and the perspective of healthcare professionals was like, oh yeah, that's for them. And so we tried to kind of really shift that and think about, well, as a physician, you have goals for your patients. How can we use technology to support those goals, right? And I think from providers, it's not so much when we talk about maybe patient-generated data, it's not even always the data. It's the fact that the patient is now tracking the data and being engaged and taking ownership. That's where the difference lies. So I think in terms of staff, there's a principle of trialability. So we have maybe test accounts. So we have a My HealtheVet coordinator at every facility in the country, and their role is local implementation. So we engage with them, and they in turn turn to their clinical communities and engage with them. So you've got the spirit of kind of clinical champions. And if those folks have access, easy access to provide education and training that's relevant for the intended audience, such as providers, then I think that's the pathway that will help them to become kind of ambassadors of the program. And then I think it's also important that, if you are working in a constrained system, there has to be relative advantage, right? So secure messaging is a great example. And because we don't offer remuneration for services, instead we now allow them to claim workload credit. So I can save a particular secure messaging encounter as a progress note in the electronic health record system. I can claim either workload credit or increments of time. Now that doesn't translate into money, but it certainly might translate into panel size right sizing, right? So if I'm a provider who's got workload credit because of my activity using secure messaging with patients, then I can use that to adjust my panel size. So I think it's really thinking about from the perspective of the physicians and all the other allied health professionals and nurses, how we can really try to understand from their perspective what's important. I learned a lot in doing those qualitative interviews with them. And it was interesting because the perspective of the pharmacist was quite different than the perspective of the nurses, which again was quite different than the perspective of the providers. So really understanding that, healthcare is team-based, understanding the different clinical processes and the roles of the members of the team, and thinking about how the technology can help them, to do that in a way that's better for the patient and also better for them.
Okay, I have another question.
Okay.
I wasn't able to grab on to all of the issues associated with interoperability. One of your issues was interoperability, but it's a little big, interoperability. And it's out in the non-VA world, we recognize that it's quite a bit of a problem. That, for example, in this town, there are 3 substantial healthcare providers. One of them is Carl Foundation Hospital and Clinic. One of them is Provena Covenant or OSF, I don't know, they just changed ownership, but it's another substantial hospital that works closely with Christie Clinic. And then there's the federally qualified community health center. Each of these 3 outfits has a different electronic health record system.
Right.
And to my knowledge, and then you could maybe qualify this a little bit, to my knowledge, it ain't easy to move a patient from one place to another in terms of that system. So you said that the VA was using a system that had interoperability. Can you just say a little more about where we're headed for interoperability? It's a little bit like half the population is using iPhones and half the population is using Samsungs, and iPhone users can't get a charge off of a Samsung, and you know what I mean? It's crazy.
So regardless of the electronic health record system, the standards define the interoperability data sets. So we have continuity of care document, for example, pre-designed set of information. Not only has it the data, but it has the metadata. So apples are apples, oranges are oranges. So it defines the data in addition to providing the value for the data. So it can be read by any health record system. So we have health information exchange, which means organization to organization, we agree that we will exchange information. And that could be direct exchange or query-based exchange. So if I've got a patient and I know that you're seen at your hospital, I can query your system and view their electronic health record data, right? Or another method would be direct data exchange. So using direct messaging, we've exchanged certificates and set up our health information exchange system. I can actually send you a CCDA health summary. So now you've got the most recent medical record of the patient, right? And that's great. But how does that apply to the patient portal? ONC would promote a principle of consumer-mediated health information exchange, right? So health information exchange between organizations is great, but it's not ubiquitous. So what about the patient? Who's the person in the room who's most incentivized to see their data shared? Who's the person in the room who knows who and where they were seen, right? So can we provide patients with tools that allow them to do health information exchange? And in fact, we can. So one of the things we have in field testing right now is called VA Health Summary, Send My Health Summary. So not only do we provide patients with the ability to download a CCDA, which is a standards-based interoperable health summary that can be read by any electronic health record system because it's based on HL7 standards. They can view it, they can download it, and in field testing right now, they can transmit it. So if they know the direct address of another provider, or maybe they use a third-party software that's like an aggregator, like a Microsoft Health Vault, you can kind of pull in all your data from various sources. They can literally enter the direct address and transmit to their CCDA to that system. So we've got kind of this big world of health information exchange, trying to do interoperability. We've got, VA to community, community to VA. We've got VA to DoD and vice versa. And in addition to this sort of health information exchange, we've also got this idea of record viewing. So for veterans who may also continue to be treated in the DoD system and may now also be VA patients, we have a joint legacy viewer. So at any given moment, we could use that viewer to not only see their complete VA record, but to also view their complete DoD record. Now we have that community viewer, so same principle. So not only can we kind of push data back and forth or pull data back and forth or have the patient do the same, but we can also have these kind of viewers that enable us to see what we need to see in order to be able to care for the patient. Does that help?
Well, it does, but it raises a question for me, and this is sort of an organizational question about the classic distinction in organ science is markets versus hierarchies. And the argument is that a hierarchy has certain advantages associated with it. It's got a single chain of command. Everything is done in-house. We can set up standards and rules and principles by which everything happens. And so the VA's health record system is an example of what can be done, in a hierarchical system like that. Mm-hmm. In the non-VA world, leaving the DoD aside for a moment, we have, at last count, something like 1,000 vendors of electronic health records. Of course, most of them are just a very small handful, like Epic and Cerner and a few others. But so the question is, why do we have all those things out there? Why do we have to worry about interoperability? And the answer is because we've got so many operators, right? If we just had one operator, we wouldn't need interoperability, right?
I think it's like, I think it'll think about like an ATM, right? Who cares if your ATM vendor is different than mine? We're still sharing the same money, right? So that's one idea. So data is like the currency, right? And as long as you can continue to describe the pedigree and the provenance of the data so we know where it came from and who touched it, then that carries with the data. That's, interoperability, right?
Yeah. There is an answer to who cares, and that is that, if I go to yours, yours are going to charge me $3 or $4 for, for using it, So I kind of care about that,
right. Well, the other point that you made me think of, I think, is the new vision is what 10 years ago came out as health record banks, right? Well, why do healthcare providers get to be the data holders, right? Why don't we have a person-centric portal place that people can keep their data, and then I can provision my data, to whoever I want to have access to that. So the 21st Century Cures Act, new legislation, calls for different principles in terms of health information exchange, but it also embeds this idea of a person-centered health record, right? So, this idea of that I have a longitudinal health record with all my data from all my settings of care, and then I control that, and I, can share that when I need to, when I'm receiving care. It's a different model, right? So, I think that's a model that's emerging, and it's not a new model, but one that's certainly gaining a lot of momentum given the recent legislation.
Right.
I don't think we have any more questions online here.
Okay.
I can ask one. So I do think that's very interesting, going to the patient perspective and imagining me, having my entire healthcare records. But from some of the stuff I've seen, and you might not be able to speak to it as much from a provider side, but I've seen patients come in and they've got like literally a folder stack of paper and like, here is everything from the last year, help me figure out what's going on. And so do you have any, and same thing even with interoperability, but physicians being overwhelmed with everything when it's, I'm, especially with our increase of specialists, where it's a small subset might be relevant, or it's, well, this you need to talk to whoever is controlling your diabetes, and I only need this here. And so as much as we talk about information being a good currency, are physicians having any concerns about being overloaded and then now having to take a lot of time to sort through everything that they now have access to? Because oftentimes patients don't know what's relevant and what's not at any particular moment. They just know something's wrong and I've got a 30-page lab report and I don't know what it means.
Right, right. And I think that's the idea behind the continuity of care document. So by definition, it's the data that's needed to support the continued care of the patient through a care transition, right? So by design, these C32s and now CCDAs are pre-designed sets of information. So, when we talked about being able to transmit this blue button report, let the patient, pick. The con of doing that is that now the burden's on the patient to know what's important to send, right? And so by design, these health summaries are specifically and defined by the standards to be sets of information that are critical for care transitions. That's one piece of it. I think the second piece of it is like the patient-generated data piece, right? Like just because I now, as a consumer, have access to all my data, that doesn't necessarily mean my provider wants to see it. But that's where I think we have to build smart use of technology, right? So technology enables us to look for patterns and rhythms and outliers. And so I might not want to see your Fitbit records for the last year, but I might want to see a pattern or a trend or a representative cycle. And so I think that's the new horizon, right? Not just generating as much data as we can, but being smart and using the technology that we have to kind of mine that data and present it in actionable ways, right? So that's what we're trying to get at, I think, in terms of looking at patterns using artificial intelligence to kind of harvest that data, but tell me the important things where machine learning could mine millions of records and come up with the story of the data, right?
Any other comments or questions from our local audience? If not, excuse me, folks. We'll adjourn our meeting now, but I'd like everybody who may be viewing this online to note that Kim's contact information is right here, and she'll be available to answer questions or entertain your comments about her presentation regarding the patient portal and the Veterans Health Services. Kim, thank you very much for your presentation today. Really, really enjoyed it. And tomorrow, our guest is Dr. Sheena Bull, Professor of Public Health at the University of Colorado School of Public Health, and we'll look forward to having you join us then. Thanks, everybody.